Hello guys. Today is our last day. Final day. Final day. Tomorrow we'll be leaving Singapore. हम यहाँ पे It's me, Dr. Sekia.
संतोषा
सर आज हमारे फाइनल डे है, तो आपका सर फीलिंग क्या है यहाँ सिंगापुर से आके आज जो हम फाइनल ट्रिप जा रहे हैं, तो आपको कैसे महसूस हो रहा है? व्हाट यू आर फीलिंग?
सबसे जवान लोग जल्दी आ रहे हैं ना, सबसे जवान लोग लेट कर रहे हैं।
होटल रूम में है क्या?
सर पहले आपको फीलिंग बताइएगा आज लास्ट डे।
We are very grateful to government of Arunachal Pradesh for sending us here.
Bus is already about to move.
Singapore, of course, ये मेरा port visit है. I visited Singapore in 2002 in the month of June. तो उससे और आज
इतना सोया है।
बहुत फर्क हो गया, बहुत हाइपर डेवलप नेशन एंड जितना रोड्स infrastructure, buildings and everything is at its best. कोई धुला बालू नहीं बसने से people very disciplined and everything is and very greenery also. Singapore यहाँ का आदमी discipline हर चीज ठीक ठाक है, खान पान and मेरा जितना आया है वो लोग सब enjoy किया. They have enjoyed to their full extent. जो भी facility बनाया right from आपका लाइट एंड साउंड शो, रिवर क्रूज, all those infrastructure like hotels, boats, everything.
Thank you sir. Sir, আপুনি কিবা ক'ব নেকি? আমাৰ ডক্টৰ सर
हमारा
लास्ट डे ऑफ
हमको
फाइनल डे है।
सर तो सब कुछ बता ही दिया, लेकिन हमको एक सिंगापुर में अच्छा लगा कि जो स्वच्छ भारत जो हमारा उधर चलता है, बात थ्योरी जो है, इसको हम लोग सिंगापुर की तरह एडॉप्ट नहीं कर सकते, लेकिन उसको मिनिमम को तो हम लोग को भी एडॉप्ट करना है। तो हमको हॉस्पिटल्स में जो कायाकल्प का जो विकल्प है, उस चीज़ को हम लोग को सीखना चाहिए। कायाकल्प कर सकते हैं हॉस्पिटल में जो काफ़ी क्लीन है, बहुत ही ज़्यादा क्लीन है। ये एक नेचुरली नहीं आता, ये अपना इंस्टिंक्ट अंदर से हम लोग को अपने आप को इम्प्रूव करना है। इस चीज़ को हम लोग यहाँ से सीख के जा रहा है। हाउ दिस थिंग्स आर मेंटेन। एक छोटा सा कागज का टुकड़ा भी गिरने नहीं देना यहाँ पे, वो कहीं भी भूल नहीं है। हमारा हॉस्पिटल में हम लोग ऐसा कोशिश करिए।
थैंक यू सर।
हम लोग के लिए ना
आप डायरेक्टर सर और आप डॉक्टर सर एज ए DMO, आप दोनों का जो बयान किया है, आपको जो फीलिंग्स है, हम सड़कों पे हैं। हम यहाँ से जाके वहाँ में इतला कोशिश करेंगे जो स्वच्छ भारत अभियान को चलाने के लिए। थैंक यू सर। एक्सक्यूज मी मैडम, गुड मॉर्निंग मैम। मैडम ये जो आप आप जो इतने टीम को लीड कर रहे हैं ना, अदरवाइज इट कैन बी पॉसिबल फॉर अस ना। 36 डॉक्टर्स को आप यहाँ लेके सिंगापुर लेके आए हैं। आपका एक्सपीरियंस ये तौर का आप तो काइंडली बयान कर दीजिएगा।
थैंक यू डॉक्टर सैकिया। मैं लेके नहीं आई हूँ, ये एक्चुअली गवर्नमेंट ऑफ अरुणाचल प्रदेश ने स्पॉन्सर किया है, फर्स्ट एवर ना, फ्रॉम डिपार्टमेंट ऑफ हेल्थ एंड फैमिली वेलफेयर। सो आई एम वेरी हैप्पी द गवर्नमेंट हैज कंसिडर्ड एंड इट इज़ रियली an encouraging thing which government has done. So I am sure many people will be encouraged and इससे थोड़ा सा ये रहेगा कि अच्छा काम करने का, because all best performers are selected from the district, recommended by district I mean deputy commissioner of the district. तो ऐसे करके हम लोग यहाँ आए हैं। Thank you.
As a team leader, your experience with the doctors?
हाँ बहुत अच्छा है, वी आर एंजॉइंग। अभी हम हॉस्पिटल जा रहे हैं, नेशनल यूनिवर्सिटी हॉस्पिटल सिंगापुर। थैंक यू।
Okay, thank you मैम।
पासपोर्ट नाला आपको पूरा एकदम
Good morning, all of you.
गाड़ी रिश्ते से
Today is our last and final visit to Singapore. Now we are going to hospital, National Medical College, Singapore. So जो भी है मेडिकल में आप लोग काइंडली अच्छे से ऑब्जर्व कीजिएगा और उसको देख के हमारे वहाँ भी हम लोग इम्प्लीमेंट करने के लिए कोशिश करेंगे. व्हाट आर द गुड थिंग्स ना, नॉट द बैड थिंग्स. इसलिए यहाँ का जो मेडिकल का जितना भी हम लोग देखने पर जो भी हमारा एक्सपीरियंस रहेगा वो हमारे वहाँ में जाके अरुणाचल में जाके हम लोग फ्रॉम एवरी डिस्ट्रिक्ट हर डिस्ट्रिक्ट में हम लोग इसको इम्प्लीमेंट करने के लिए कोशिश करेंगे. तो इसी के साथ में इसी सोच के साथ में ऑल द बेस्ट, हैप्पी जर्नी. थैंक यू फ्रॉम हेलो गाइस, हेलो गाइस. Good morning, everybody. Today is our final day in Singapore. Just we're going to visit the National Medical College, Singapore. We are on the way. आखिरी दिन का सिंगापुर का नज़ाराना देखिए. सिंगापुर की आखिरी दिन का नज़ाराना. हेलो सर, आप कहाँ से हो?
हम है अंजाव
डिस्ट्रिक्ट. योर गुड नेम?
डॉक्टर रमेश जाकर.
रमेश. ओके, थैंक यू. गुड मॉर्निंग सर. योर गुड नेम प्लीज?
I'm Dr. Rojin Komar
फ्रॉम
from TRIMS, Naharlagan, Arunachal
ओके,
Pradesh.
थैंक यू सर. योर गुड नेम?
Ronchen,
फ्रॉम
Arunachal.
Arunachal. And from where you are? In which place you are?
Rupa West.
Rupa. Thank you.
I'm also Rinchen Nima.
Rinching Nima. Tawang. Thank you. I will visit next time on December 15th. Sir, your good name, please.
I'm Dr. Kur Jarbo. I belong to Zero, Arunachal Pradesh, India.
Okay, thank you, sir. Good morning, all of you.
Good morning,
May I
sir.
know your name, please?
My name is Yasmin Basso, and I'm from BH Palin.
Palin. Thank you. And you?
And myself, Dr. Fatal Kuku, and yeah, I'm from Colorian.
Thank you.
I myself Dr. Mubat Abdul Mubat, Torsian, NCPSC.
Your good name, sir?
I've done already.
Yes, sir. Okay, thank you. Sir, your good name?
I am Dr. M. K. Longchang.
From? Ma'am, good morning. Your good name?
Myself, Dr. Julian Bongo, from CHC Murumugli Kamlet.
Thank you. Sir, your good name?
Dr. T. Basser, Medical General Hospital, Comsar.
Okay, sir, good name, please. Okay, thank you. Welcome, sir. Sir, your good name?
Dr. J. Jongluju, General Specialist, Chest Medicine, District Hospital, Sempa.
Thank you, sir. Excuse me, sir. Good morning, sir.
Hello,
Your good name, sir?
I'm Panataku,
Okay, sir.
epidemiologist, DHS office.
Thank you, sir. Excuse me. Good morning. Hello, sir. Sir, your good name? Please. Sir, your good name?
Myself, Dr. Ravi, working as a medical officer in Pakistan district.
Okay, thank you. Good morning. Your good name?
Good morning, sir. I am Akar. From CSC Metro.
Good morning, sir.
Good morning, I'm Dr. Triti, Dear Chicho Leparada.
Thank you, sir. Good morning.
Hello.
Sir, please,
good morning.
your good name?
I'm Dr. S. Tong from Teju.
Okay, thank you, sir.
Hi, good morning.
Your good name?
Siam Thamung from Namsai.
Sir. Thank you, sir. Hello, excuse me, sir. Your good name, sir?
Hi, my great name is Dr. Tasar Thania and representing Great India in the US, Singapore.
Okay, thank you.
Good morning. I'm Dr. Khalid Taho from Pasian District, Arunachal Pradesh.
Thank you. Excuse me, sir. Good morning.
Morning.
Your good name, sir?
I'm Dr. P. Rakshit. I'm DSO, come DPO and city, DSO IDSP, District Tirau.
Okay, thank you, sir.
Posted in General Hospital, Khunsa.
Excuse me, ma'am.
Yes, yes.
Your good name, ma'am?
Bombay time.
From Narlagan.
Yes, yes.
You are the program organizer, okay, sir?
Yes, yes, yes.
Thank you, ma'am.
Good morning, sir.
Good morning.
I am Dr. Tuten Roma from Bomdila, West Kameng district.
Okay, thank you.
Good morning, sir. Sir, I am Maman Ferdin, currently working as a senior nursing officer in Prince Hospital, Itanagar, Arunachal Pradesh. And regarding this trip, today is our last visit to hospital. And regarding this trip, I really feel honored and happy to be included in this part. And I see this trip as a chance to grow and learn. And I hope I will bring back more about this trip to me. And also, I'd like to thank our organizer team, ma'am, who has supported us from the very beginning, and also the selection committee who has considered me trustworthy of included in this trip. And I'm really happy I'm in between the talented doctors on board, and really everyone here are very supportive and which give me positive energy. And I hope to bring back lots from here, sir. Thank you so much.
Okay, welcome. Excuse me, sir.
Hello,
Your good name, sir?
my name is Dr. Danko Ira. I'm a pediatrician. I'm looking after all program activities also. I'm from the Laratipang district from Ironing. So this trip was very good, and I sincerely thank to our government of Arunachal for sending us for this tour. And from here we have learned a lot, and we will try to replicate this their cleanliness and their what they are doing in our place also. And recently I'm so lucky that I am recently a member of the recently launched the greenery mission in our village. We are trying to convert our village into a like this Singapore one, and the mission is called M3. M3 means Meka Mowing mission. So it is basically all mottos objectives are same like this. So we are trying to, and our motto is to convert our village into a greenery come a fruit village. So I have I've learned a lot and from here and ideas. So repeatedly I'll try to replicate in our hospital and in our village. So thank you so much.
Okay, welcome, sir. All the best.
Thank you.
Say your good name.
My name is Dr. Karkendrina. I am medical superintendent at Alo General Hospital.
Okay, thank you, sir. See you next. Good morning, sir. Sir, your good name?
My name is Dr. Dilip Datta.
From?
I'm DMO Longding. Okay, from Longding district.
Thank you, sir. Excuse me, sir. Good morning, sir. Sir, your good name, please.
Good morning, I am Marga Sora. I am Mission Director, National Health Mission, Government of Pradesh.
Okay, thank you, sir. Welcome.
आओ अभी भी तो 1-2 बजे भी जा रहे हैं ना
Thank you, all of you, for introduction. Give introduction yourself. Thank you.
Hi guys.
Why? ये एक अपना अपना क्वालिटी है ना. Thank you. Bye. And that's NUHS. National University Hospital Singapore.
कुत्ता ऐसे बकरा आगे रगड़ते रहेगा.
हॉस्पिटल के अंदर का नेशनल यूनिवर्सिटी हॉस्पिटल सिंगापुर.
तो हॉस्पिटल ऐसे बनाने से भी तो कहाँ चलेगा वहाँ.
हम लोग उधर में कहाँ एक महीना में खराब हो गया. क्या है ना जहाँ मत
Thank you very much. Thank you very much for coming to. No. Right, okay. So, National University Hospital is one of the academic hospitals. What I'm going to share, I know we're here to hear about geriatric medicine. I'll share a little bit about the healthcare system in Singapore so you understand a little bit more about where does the hospital stand and everything. My name is Professor Rashwa Merchant. I'm the head of geriatrics. Coincidentally, I actually started the geriatric service at National University Hospital in 2004. So we are kind of 21 years old in Singapore at National University Hospital. A little bit about Singapore. Singapore, you would know by now since you toured Singapore, it is a little red dot in Asia. Our population, we are very, very densely populated, almost about 5.9 million of residents. Currently, about 20% of our population is above 65-year-old. It's probably very different. I think India as a whole is probably quite a young population. And we are aging so fast that by 2030 we'll be 1 in 4, and by 2050 it's going to be 1 in 2 above 65-year-olds. So really, when we decided to develop geriatric medicine in Singapore as a whole, we were really trying to look at our demographics and how we move forward. So besides that, Singapore has got one of the top 10 highest life expectancy at birth, right? About 84 years old, so both sexes is 84-year-old. Female life expectancy is 86.5 years, and male is 81.5 years. And really, people are living longer, and even if I have to share with you the average age of my clinic patient is 90s. So when they come and see me in their 70s, I say, you're still very young for me. This is where we are in Singapore. So while we are all aging, and in many, many countries, there's a big gap between the health span and the lifespan. While we live longer, the question is, how can we compress the mobility? We live years in disabled life for shorter period. Currently, the gap is about 10.8 years in women and about 8.7 years in men. So we're trying to do a lot of initiative in the community to reduce the gap between lifespan and health span so they can age at a very healthy manner. So Singapore healthcare system, we go by clusters. So there was National Healthcare Group and SingHealth. So there are 3 main clusters. But if I have to just share with you about National University Hospital, we are the academic medical system, but also we are tertiary acute and community hospital. So you are in National University Hospital. We have Ang Teng Fong Hospital, Alexandra Hospital, and we also have a community hospital, which is for subacute care. We do have national specialty centers, such as the National University Cancer Institute, Heart Institute, and Oral Health. Polyclinics, we do have National University Polyclinics, we have Medical Center, and we also have academic health sciences institutions, such as the Yong Lin School of Medicine, Alice Lee Center for Nursing Studies, Sosui Hawk School of Public Health, and Faculty for Dentistry. So really, and all of these, in terms of health sciences institution, they are attached here, but some of the other hospitals, they're between 5 to 15 kilometers away. So Singapore as a whole, while the emphasis probably I would say until 5 years ago, a lot of it was sick care, we are moving towards healthier SG, which is preventive health. And essentially what we're encouraging everybody to choose a family doctor, and and they'll be invited, and they'll have a personalized care plan, and each of them will get a social prescribing. Yeah, what is healthier for you, how you need to do. And amongst this, some of you may be familiar, but we're also rolling out the WHO Integrated Care for Older People, ICO, to screen for intrinsic capacity in the community. We're working with a lot of our active aging centers. In the whole of Singapore, we have 220 active aging centers. They are not owned by us. They're owned by NGOs, a lot of them. But we, as an academic center, we work with the NGOs to facilitate screening and the subsequent interventions. We also have been tasked to take care of the population health of the Western region. And in the Western region, we are supporting about 1.18 million of residents in the Western side. And we actually have a community care team in the community. So every region, there are 27 community care teams in the Western side, and they work again with the community partners for preventive health, as well as those with discharge to the community. They will be the nodal point to go and have their blood sugar checked or their blood pressure checked. So it's literally housing estates. They go down and they have their medical health checked. So we are very lean geriatric team. This is our NUH geriatric team. Yes, so it's quite a small team, and this is consultant team. And what do we have for geriatrics? So we started in 2004, and we started from literally working together with internal medicine, and all the patients used to come in under internal medicine, and we used to have a nurse practitioner who used to screen for anybody with geriatric syndrome, which is falls, continence, confusion. And then we used to take over, because our worry at that point, because there was only me for a few years, but eventually, if you say everybody above 75, everybody will be under geriatrics, right? So we started with that, but now we have dedicated inpatient beds. So everybody above 75-year-old admitted in any of these wards under internal medicine are our patients. So every year we've been discharging about 2,600. So every month is about 220 patients. And our median length of stay is 3 days. Median. Mean length of stay is about 5 days. Yeah. Sorry? Yeah. Yeah. So really, because in academic hospital, our mission is also to turn over patients fast. We do have a silver unit, which is for delirium. I'll share with you. We have a consult service. We call it Mobile ACE, Mobile Acute Care of the Elderly for Blue Letters. We also have nurse-led service, for under surgeons if the patients are confused. Sometimes they may not want to refer doctor to doctor, but the nurse to nurse, they can still refer for advice. And we do have an acute care of the elderly unit, which I'll share with you shortly. When we first started in NUH, because we were very, very lean in geriatric physicians, we worked with the nurses. So in every ward, we have nurses trained in have diploma in geriatric medicine. And then we developed this nurses improving care of the health system for elders program, elder care bundle, and also nurse-led swallowing screen program. And we do a lot of collaborative care. So we do have oncogeriatrics, orthogeriatrics, community care team, geriatric emergency department, geriatric nephrology, and geriatric surgery. So acute care of the elderly unit, initially it was just a general ward. And then we realized the patients who came up to us direct from the emergency department shared on average 2 days shorter length of stay. So we have acute medical unit where the patients can go to the acute medical unit and come up, or the patient can come up to us directly. So we decided that patients are going to turn around very fast, they'll come up straight to the ward. So it's about right sighting. So patients who come in do get a comprehensive geriatric assessment by the nurses and targeted interventions, early discharge planning, reducing overall length of stay. We work with radiologists. We tell the X-ray, the radiologist, we put ACE unit, we will get the appointment the same day. Yeah. And also the nurses, they will do assessment and they'll put it there. Who's a caregiver, what's the baseline function, what's the contribution, and things like that. So as I said, the why is because we do have a couple of papers published. So this one we actually showed that patients who came directly actually showed much shorter, and after starting our median length of stay is about 3 days. This is our general ward. We do have a lot of activities for the older people and volunteers. So this is our silver unit. It's basically for persons pioneered. So we've got this skylight here, and this was adapted from the geriatric emergency department in Mount Sinai. They actually have a similar ceiling, so it looks like it's daylight or nighttime. It's restraint free, so we do not restrain our patients. And they do have a lot of activities there as well. And this was our previous president of the country who had visited our silver unit before. Yeah. And yeah, so basically we also showed that with the silver unit, our length of stay with delirium is also a lot shorter. And there's also this paper to show we studied patients who came under geriatric medicine and versus non-geriatric medicine. So patients who came directly under us actually also stayed shorter and was cost saving. Because traditionally, there's always been this misnomer that geriatric medicine, older patients stay longer, but that's not true. If they get the right care in the right time, in a timely manner, they actually stay much shorter. So we do have outpatient service, again, is above 75-year-olds, those with geriatric syndromes only. And we do have nurse practitioner run memory clinic, because a lot of the time it's relatively simple. And again, annually we see about 3,000 people in outpatient clinic amongst 6 of us, and we have a few trainees. We do have a RACE clinic, which is rapid access clinic for emergency departments. So instead of admitting them, they send them home and we see them early within 1 week. And also for early review, we do have geriatric perioperative service. If you want, the anesthetists are concerned, they can refer to us. And we've just started a geriatric nephrology multidisciplinary service, especially useful for people who are undecided whether they should go for dialysis or not. And they do have a geriatric nephrology board meeting as well on a monthly basis when they discuss dialysis. So geriatric oncology, we've been around for a few years now. It's together with the oncologists. Again, we evaluate whether they will benefit from chemo. We will guide them about chemotoxicity. There's frailty assessment. And basically, they've just started about frailty screening and assessment of radiotherapy at the radiotherapy center. We're also trying to upskill the geriatric advanced practice radiation therapists, and everybody who will go into the National Cancer Center, they're older, they will have geriatric assessment. So this is going to be one of our Center for Excellence in the coming years. So in terms of collaborative care, the other collaborative care, I know a few of you are surgeons as well here. We do have ortho-geriatric service. And last year we did win a couple of awards in terms of reducing length of stay from 11.7 days to 10 days for hip fracture patients. So we got the Incredible Care Award. We do have a geriatric emergency department pathway. If there are patients down there, a nurse practitioner can go down. I mentioned about community care team and geriatric nephrology. So we do try to work together because we are the academic center. Very much multidisciplinary care. As I said, when you come the next time, maybe. So these are our nurse clinicians and nurse practitioners, our social worker. These are also our nurse practitioners. Now, one of our papers, we do have this. So again, if you are thinking of starting something in your hospital without many geriatricians, we do have this elderly care bundle. So, as I said, you could just look at the paper that I published. It's actually in there, but every patient who comes in do get a post-ward residual urine, get a postural blood pressure. They will look out for delirium, for continence, for cognition. So there's this whole protocol that they have to follow. So above 65-year-old nursing assessment, identify problem, refer to the guideline, and then it's just nurse-led intervention. So when we started the elderly care bundle in 2006, our inpatient falls rate also reduced significantly. And they were kind of they were much lower than the so-called worldwide standards. So the way we work with the geriatric care nursing is the enrolled nurse or registered nurse will initiate elderly care bundle, and then the registered nurse will screen patients who have got problem and refer to geriatric resource nurse. So every ward there's a geriatric resource nurse. Geriatric resource nurse asks for memory clinic appointment or for false appointment. If a patient is confused, they will call us and say, hey, this patient is really confused. Can you please take them up directly to your delirium unit or silver unit? And this is just about things. These are the patients. This is 2016. It was very old. But they identify false-related cognitive impairment, and then these are their referral. They refer to therapists. We realized there was very little of geriatric education. Even when there was, the exam question was very simple. These 4 courses of forms. Even you don't, everybody lists those 4 courses of forms. We changed the whole education system to make sure we work from bottom up. So currently we do have undergraduate level, which I'll share a bit more. We did improve on the communication skills station. We have a foundations in aging program year 2 to struggle. Right? So this is where we advocate and we work together with nursing and everybody else. So just a simple example that is very longitudinal. So we do have basic science where, in pathology, physiology of aging, microbiology. And then in year 2, we also have a 2 weeks foundation in aging program. Year 3, we have lead medicine posting, surgical posting, family medicine posting. We do have professorial grand rounds as well. We get them to present. Year 4 now offer geriatrics, and then year 5. House officer, every house officer needs to do at least 1 month of geriatric medicine posting. Yeah? And then once you're in residency program, you need to do at least about 1 month a year. So that's about 3 months. What we do in the postgraduate, what we call registrar or fellowship posting, before they become specialists, they must do every year, this is required by Ministry of Health, every year they must do at least 2 months of geriatric medicine or internal medicine. Because again, whatever they do, they're going to face patients who are old or with multimorbidity. So this is basically undergraduate. We really have our say in what we want to do. When we try to develop the modules in basic science in year 1 and year 2, we face a lot of resistance from basic science. So that is why you need clinical geriatrics in year 3, but we had to push it in to just make sure the students are aware how important is geriatric medicine. So we residents in research projects, scholarly activity. We also have our foot in the internal medicine residency program, role models, and as I said, for those who are senior residents, they must rotate to us. We also have a specific geriatric medicine senior residency training. It's a 3-year program. These are our core faculty and our trainees, and essentially what they do, they have got about 2 years of acute geriatric posting. They do 6 weeks of hospice care or palliative care, 4 weeks of rehab, 4 weeks of psychogeriatrics, community hospital 4 weeks, long-term care 4 weeks, community care team, and we do about 8 weeks of those medical-related posting that will be useful for them, like neurology, rheumatology, neurology. We do have programs. We have a graduate diploma in geriatric medicine, mainly for GPs, which once a month they have workshops and they have lectures. We do encourage GPs to attend this, and it's actually run by the graduate school at the university. We do a lot of research. So in the number of manpower we have, we do quite a bit of community-related research for geriatrics, geriatric emergency. Yes, so these are some of our funds as ongoing projects. In the last year or so, we've embarked quite a bit on data analytics. You want to share your program that you have there.
Thank you.
Yeah. Do you have a slide to present?
there is anything you ask, then you can.
We can just share as Madam. I'm the state nodal officer, like where I'm looking after the therapeutic program in our state. Yeah. So, like you said, for us it's from.
I'd like to present some, gift which our secretary, Madam Hira Singhal ma'am, she actually arranged for this entire. She is the secretary health for government of Arunachal Pradesh. We are all employees of the government of Arunachal Pradesh. So as per her direction, we brought. So we will have that. Ako na ba ako na ba? Madam, ako na.
Madam, can your photo be your national youth?
This one?
Yeah, this one.
Sir,
Ma'am, this is one of our traditional markers. Wow, so it is handmade.
Madam.
Wow. This is wine. I don't know whether you drink, but it's a kiwi wine which is made only in our place. Yes, yes. Thank you so much. So I would like to request Ma'am Diana to come forward. And thank you, ma'am, so much. And I'll request Michelle, ma'am. It's just a small token.
From our state.
Hey, Dr. Rakshi.
आप लोग ग्रुप फोटो ले लीजिए सर, हम लोग नहीं रहेगा सब तो नहीं कांड में रात बहुत चला ग्रुप
Thank you so much.
Most of the genetic patients used to suffer from cancer related illness. So, how you integrate genetic care and palliative care?
It's actually a fantastic question. So when we first started, again, I'm going to share with you when I first started, so it's easier for you to understand. When we first started, palliative care was also very new. So a lot of our palliative care was stationed under cancer which is from children all the way to adults. So most of the palliative care in older people was handled by geriatricians, right? So we used to go around advocating end-of-life care, symptom control. And I know some of you are also from Ministry of Health. One of the things that Professor Benjamin Ong, who used to be our previous Director of Medical Service, did when he was head of medicine, he made a geriatrician to be head of internal medicine. Because he said we need to change the culture. So all the internal medicine meetings was actually led by geriatrician. You saw the bedside rounds. So this is where we even brought in end-of-life care within internal medicine. So now, after all these years, palliative care now has branched out from internal medicine. There's a group under internal medicine doing palliative care, but we still continue to take pride in doing end-of-life care in those with dementia, prioritize care in those with cancer patients towards the end. You know how sometimes they want to do everything in every scan, and you say, hey, stop. You know, she's 95-year-old, she has poor physical so that advocacy has to be there. Again, it doesn't, even if it's not a geriatrician, but I think the person who's advocating it has to be somebody who's known in that unit or in that hospital. And I think, well, the other thing that I have to, again, I think Diana would actually, Department of Medicine and National University of Singapore, every time for every meetings, every grand round, every mortality round, regardless of specialty, when the person was elderly, he will say, where's Reshma? Reshma, do you want to give your input? So again, have at that institution level that highlights the importance of geriatrics is very, very important. So because he used to give me airtime, I used to then speak and said, you know, it could be a surgeon, it could be an orthopedic doctor. I just used to stand up and say, maybe we should have operated on this hip fracture even though she was 90 because she was in a lot of pain. Right? So I think that authoritative figure, whatever you do, has to be there. And it's also important if you're starting off afresh is to have your nurses trained, have your, you know, allied health, like exactly what you do. Because there was only one geriatrician in this hospital for 7 years. 7 years. One. Right. So sometimes, and I still, even with one geriatrician, we still had 400. We used to discharge 400 a year. We still had outpatient clinic. We used to collaborate.
To improve the quality of life, what's your approach or opinion regarding home-based care?
I mean, again, you see, the home-based care, as you said, I think in countries like India, because you do have very good families. Okay, we have two main types of home-based care. One is hospital at home, where, you know, patient who needs antibiotics, ongoing, we have this short stay there. Then we have the community care team for those who need prolonged care, like wound care and other things, where they will work with the family members. It's all possible, but number one is availability of caregiver, number two is the funding. So the country also has to play a role about, you know, who's going to fund these people in the community. And it's all about upstream. You see, I think what we focus on home-based care when they're near the end of life. We do have home medical and services. Right? Those are I would call it pre-frail, or maybe if you're talking about clinical frailties care, it's probably between 4 to 6. How can we actually provide a care ecosystem? But before that, in every DGH, what we're trying to do as well, like every block of flats, we're trying to see what is the proportion of them are frail, what proportion of them